The following podcast is part of a certified educational activity titled Evaluating the Evidence and Parsing the Practicalities of Therapeutic Choices in Advanced and Early HR-Positive Breast Cancer. Expert perspectives on Cdk4 and 6 inhibitors and other novel agents, featuring Dr. Sarah Tolaney, Erica Hamilton, and Kevin Kalinske. Access the entire activity and complete the post-test at peerview.com/HCT860. Downloadable slides and practice aids are also available.
Well, welcome to our program on evaluating the evidence and parsing the practicalities of therapeutic choices in advanced and early hormone receptor positive breast cancer. We'll be looking at expert perspectives on CDK4 and 6 inhibitors and other novel agents. My name is Sarah Tolaney, and I'm from Dana-Farber Cancer Center. And today I'm joined by two expert colleagues, Dr. Erica Hamilton from Sarah Cannon Research Institute and Tennessee Oncology, as well as Dr. Kevin Kalinske from the Winship Cancer Institute at Emory University. Before we begin our presentation, let's briefly focus on disparities in breast cancer clinical care and research. This was the focus of this year's ASCO, really trying to focus on recognizing disparities and needing to provide equitable care to all of our patients with cancer. The Tiger Lily Foundation has partnered with us in this program to bring in the patient perspective and really shine a light on disparities in breast cancer clinical care and research. Mema Karmo is the founder and CEO of Tiger Lily. She herself is a 15-year survival of triple-negative breast cancer, and we're going to hear from her about her journey.
Hi, I'm Mema Karmo, a 15-year breast cancer warrior. When I heard the words, "you have breast cancer," my life changed, and I had to think about how to save my life, but then also how to ensure other women had access to the right kind of treatments in time, and how to help them be their best advocates as well. So while in treatment, laying in bed, going through chemotherapy, I began a nonprofit that's grown called the Tiger Lily Foundation that helps to educate women of color, women of all colors actually, but those who are facing cancer at a higher risk, who are women who are dying of the most of breast cancer, young women, and brown and black women. So our mission is to educate, advocate for, empower, and support women going through breast cancer, and to ensure that we work to end disparities of age, stage, and color in our lifetime.
We know that Black women have lower rates of diagnosis of breast cancer than white women, but are diagnosed at a younger age, at later stages, and with more aggressive subtypes, and have the highest death rate. We're going to hear from Jamil, a patient with metastatic breast cancer who's encountered many barriers after her diagnosis at a young age.
Black women die of breast cancer at a 40% higher rate than white women. The narrative was, oh, well, it's personal responsibility. They just don't have enough money. Then it was access to healthcare as to the reasons why, we have these disparities. However, what was interesting, though, is that in those areas where all things are equal as far as treatment, insurance, and those things are not a factor, that they still had disparities in their survival outcomes.
Racial and ethnic minorities are more likely to experience delays in therapy, less likely to obtain adequate treatment, and are also significantly underrepresented in clinical trials. Let's hear from Lori, a physician and patient with metastatic breast cancer who advocates for more diversity in clinical trial participation.
What we know about clinical trials is that not enough Black women are in clinical trials. Less than 10% participate in clinical trials. We know that when we look at the statistics, it's about being asked, it's about being considered. I know that with this diagnosis that it is an opportunity for me to give a voice, to give a platform to women that look like me that may not have that opportunity.
Taking meaningful action individually and jointly to acknowledge and overcome disparities in breast cancer clinical care and research is an important focus of today's discussion. Let's hear again from Mema Carmo, the founder of Tiger Lily Foundation.
So what I want to leave you all with today is this, that as a provider, you are your patient's best advocate. The healthcare system is very complex, and right now we're dealing with multiple challenges with COVID and cancer. But the thing is that you went to medical school for a reason and took an oath to be that person who's there for your patient. So each patient you meet is an individual person with their own challenges in their life and their cancer care. And your job is to make sure they have access to the high quality, equitable care throughout their cancer journey. And so I'm calling on you today to ensure that everyone you meet, every patient you meet, you have the power to change that person's life and work with them in a way that's actionable to ensure they have quality care throughout their cancer continuum.
So next, let's turn to our program, which will focus on expanding options and making critical decisions in patients who had advanced hormone receptor positive breast cancer. We'll first start out with a focus on Cdk46 inhibitors. And to put this into perspective, we'll start with a case that you can keep in the back of your minds as we talk about Cdk46 inhibitors, and then we'll circle back to this case to get everyone's thoughts on that. So this is a 54-year-old woman with a history of stage 2 hormone receptor positive, HER2 negative breast cancer, who 4 years ago had received adjuvant chemotherapy with adriamycin, Cytoxan, and Taxol, and then was put on an aromatase inhibitor. She developed right hip pain, and imaging revealed lytic bone lesions. Staging scans also revealed liver metastases in addition to the bone metastases that could be seen. A biopsy was done of her liver, which did come back consistent with her original breast primary, so it was also hormone receptor positive and HER2 negative. She did have genomic sequencing that was done on the tissue from her liver biopsy, and this did reveal a PIK3CA mutation. So how would you recommend first-line therapy for this patient with metastatic hormone receptor positive breast cancer? Would you consider fulvestrant alone, fulvestrant with alpelisib, fulvestrant with a CDK4/6 inhibitor, exemestane with everolimus, or capecitabine? So now keep this in mind, and we'll return back to it after we touch upon the CDK4/6 inhibitors. So as you all probably know, cyclin D interacts with CDK4 and 6 to phosphorylate the retinoblastoma protein. This results in release of E2F, which then results in transcription of key genes that are necessary to really move from G1 to S in the cell cycle. We know that inhibiting CDK4 and 6 can result in halting this cell cycle at that G1S transition point. Therefore, those cells can go into a senescent state, and sometimes prolonged senescence could eventually lead to apoptosis. This has been an area of interest for patients who have hormone receptor positive disease, because we know that hormone receptor positive breast cancers do preferentially overexpress cyclin D, making this an attractive target in this subtype. We do have 3 FDA-approved CDK4/6 inhibitors: palbociclib, ribociclib, and abemaciclib. These drugs are slightly different, both in their biology and in their toxicities. All 3 of these agents, though, are approved to be utilized in combination with endocrine therapy, either in the first or second-line setting for metastatic disease. Here you can see more specifically the key differences between the 3 agents. You can see, first of all, that there are differences in their toxicity profiles, with both palbociclib and ribociclib causing more marrow toxicity with higher rates of neutropenia, whereas abemaciclib has more GI toxicity, where we do see diarrhea. The drugs are also dosed differently, whereas palbociclib and ribociclib are given on an intermittent schedule, so they're given for 3 weeks on and then 1 week off. This is in part due to the fact that these agents do cause neutropenia, so they need that week to recover before they can start a new cycle, whereas abemaciclib actually can be dosed continuously. So it doesn't need to have a week off, again, because it's not causing as much neutropenia as both palbociclib and ribociclib can. Another unique toxicity of one of these CDK4/6 inhibitors is that ribociclib can also prolong your QTC. So this does mean that it is important to monitor QTC intervals in any patient getting ribociclib with EKGs that should be performed every 2 weeks during the first cycle. We do know that CDK4/6 inhibitors do have a different preferential selectivity for different types of breast cancer. So we know specifically that CDK4/6 inhibitors are able to cause cell death better in cancers that are of luminal histologies. So we see specifically that these luminal hormone receptor positive breast cancers are very sensitive to CDK4/6 inhibition. And interestingly, so are HER2 positive breast cancers. But you can see to the far right that in fact, triple negative breast cancers or basal-like cancers are not very sensitive to CDK4/6 inhibitors. But again, because we know that ER positive breast cancers are sensitive and we know that cyclin D is often overexpressed in this subtype, much of the work with these agents has focused on hormone receptor positive disease. And in fact, what we have seen is really tremendous benefit from these agents in patients who have metastatic hormone receptor positive breast cancer. So here you can see outcomes from 3 different pivotal trials, which looked at each of the CDK4/6 inhibitors in combination with aromatase inhibition in the first-line metastatic setting. And what you see in essence is a doubling in progression-free survival in this first-line setting, regardless of which CDK4/6 inhibitor you use. You really see that, again, you can double PFS. And interestingly, you also see this in the second-line setting. So while these trials shown here used a fulvestrant backbone, you can see that adding, whether it's palbociclib, abemaciclib, or ribociclib to fulvestrant, again, in essence, you double progression-free survival. One question that has come up is, are these agents equally efficacious in premenopausal patients as they are in postmenopausal patients? So the first 3 trials that we showed that looked at combinations with letrozole were specific to the postmenopausal population. But in fact, we also have some data in premenopausal patients. I think the most robust data really comes from the MONALEESA-7 study, which specifically was a trial just for premenopausal patients in a first-line setting population where patients all got ovarian suppression and then got choice of endocrine therapy, either tamoxifen or an aromatase inhibitor, and they were randomized to receive that endocrine therapy with or without ribociclib. And again, we see, in essence, a doubling of PFS. And while Paloma 3 and Monarch 2 used a fulvestrant backbone, these trials allowed for patients who are premenopausal to receive ovarian suppression and go on to the study. And even in these subgroups of premenopausal patients, you're seeing benefit that is similar to the overall patient population in these trials, suggesting that when ovarian suppression is given, we are seeing similar benefits in premenopausal patients, in my mind, making it important to consider CDK4/6 inhibitors also in our premenopausal patients. So while these data clearly show a dramatic improvement in progression-free survival, we had all been very eagerly awaiting to know if these agents were actually going to really improve overall survival. And I think what we're all very excited to see is that they do. So some of the early data that we got regarding survival came from Monarch 2. This was the trial predominantly looking at a second-line population of fulvestrant with or without abemaciclib, where here you can see a survival improvement from about 37 to almost 47 months. And interestingly, when you look at the subgroups in this trial, you see even greater survival benefit in patients who have primary endocrine resistance compared to those with secondary endocrine resistance. And this was kind of contrary to what we've seen with other trials where the primary endocrine refractory patients are even having greater benefit. And there has been something to this with abemaciclib where it seems to be that patients who have clinically concerning characteristics, so for example, patients who have visceral metastases, have short disease-free intervals, have high-grade tumors, and now even endocrine-resistant cancers are deriving even greater benefit than patients who may have lower risk disease. We also at ASCO this year saw updated survival data from Paloma 3. And what was really impressive was with longer follow-up, we are now seeing a significant improvement in overall survival. And when they looked at the subgroup analyses from this trial, they did find that patients who had not received any prior chemotherapy in Paloma 3 had a larger survival benefit, whereas we did not see survival differences in those patients who had prior chemotherapy. And I think that's important to realize because Paloma 3 of all the second-line trials allowed for the most heavily pretreated population. And so I think initially there was some concern that maybe we weren't seeing survival benefit with palbociclib given the initial Paloma 3 findings. But I think here you can see with longer follow-up, there is survival differences. And it was probably the more heavily pretreated patients that were driving those survival curves, probably not to separate as much with earlier follow-up. We've also seen data from Mona Lisa 3, which was updated also at ASCO, again showing very impressive survival differences between the two arms. Again, important to realize that Mona Lisa 3 was a little unique because this trial combined both first and second line patients. So it's a study that randomized patients to receive fulvestrant with or without ribociclib. And here again, you see very nice separation of the curves with significant survival differences in the overall population. So I think, again, what we've learned is that adding a CDK4/6 inhibitor to endocrine therapy is improving both progression-free survival and overall survival. But I think there's been questions in our mind about, are there particular patients who derive more benefit from CDK4/6 inhibitors than others? And are there patients who may be able to get away without CDK4/6 inhibitors? We've all had patients who've had very prolonged benefit from just endocrine therapy alone. And it makes you wonder, are there people who could get away without one, and who are they? And I think at this point, unfortunately, we don't have a great answer to that, because what we've found is that we cannot really identify a patient population that is not deriving benefit from CDK4/6 inhibition. And this is true when you look at clinical characteristics, as you can see here from forest plots looking at progression-free survival across both Paloma 2 and Mona Lisa 2, where you really see all subgroups are deriving benefit. And this is also true with our biomarker data, which I think has been a challenge for us, is that when you look at various biomarker predictors, we're not able to pick out a group of patients that is not deriving benefit from CDK4/6 inhibition. So I think at this point, our biomarker of benefit is really the estrogen receptor. So anyone who has ER-positive breast cancer with metastatic disease, in my mind, is a good candidate for endocrine therapy with a CDK4/6 inhibitor. Another question that we've all had is there an optimal endocrine backbone to use when you're giving a CDK4/6 inhibitor? And some data that we have for this comes from the Parsifal study. We had previous data that has suggested that maybe fulvestrant is a little bit better than an aromatase inhibitor when compared head-to-head in the metastatic setting, although I think we've all been a little cautious about those data because mostly those data come from patients who haven't really had much prior endocrine therapy. So most of those data come from de novo patients with very endocrine sensitive disease. And so there was some question, if you took an endocrine sensitive population, so a population where we think fulvestrant may be better than an AI, would that lead to better efficacy even when you combine these endocrine agents with a CDK4/6 inhibitor? And so that's what Parsifal really looked to address, is they took an endocrine sensitive population, they randomized them to get fulvestrant with palbociclib or letrozole with palbociclib. And interestingly, they saw no difference. So it was not non-inferior and not superior. So really they're performing the same. And so in my mind, this to me means that the endocrine agent that you're choosing when you're giving a CDK4/6 inhibitor to an endocrine sensitive patient doesn't really matter, that the patient's going to do equally well whether you give fulvestrant or an AI. And so my decision-making with choosing an endocrine backbone really comes more from what prior endocrine therapy have they received. So if someone's had a prior AI and relapsed on or within a year of that AI, I'll use fulvestrant. Whereas if someone is completely endocrine naive, I'll use an AI. Or if they're 2 years or more out from their AI, I can use an AI in that setting as well. So it's not really changing my practice patterns when choosing endocrine therapy. So what do we do when someone progresses on a CDK4/6 inhibitor? Should we continue using a CDK4/6 inhibitor and maybe swap out the endocrine backbone? And the truth is we don't have an answer to this question. There's some interesting case series that have been published suggesting maybe there could be benefit to using CDK4/6 inhibition beyond progression, but at this time we don't yet have data from randomized trials. There are trials that are ongoing that we're eagerly awaiting data from, including Maintain, looking at using ribociclib post-progression, and PACE, looking at using palbociclib post-progression. And so personally, outside of a clinical trial, I am not doing this in clinical practice. I do not reuse a CDK4/6 inhibitor with second-line therapy if they've gotten one in the first-line setting. I think we do need more data here. And I wonder if it may be more specific to what genomic alterations are driving resistance to CDK4/6 inhibition that may help us better decide which patients could benefit. And so I think we need a lot more data here, but I think important information for us to learn. Another important thing to think about is whether or not CDK4/6 inhibition with endocrine therapy performs just as well as chemotherapy. I think we've always thought of endocrine agents as working more slowly. And so when we have a patient who has visceral crisis, sometimes we get quite eager to turn to chemotherapy, thinking it may just take too long to see benefit from endocrine therapy and CDK4/6 inhibition. And so I think having data where these strategies have been compared is quite helpful. And so we do have data from a couple of trials. One of these trials is the PEARL study, which took patients and randomize them to give endocrine therapy with palbociclib or to receive capecitabine. And in fact, what we saw was there was no significant difference in outcome. So they performed similarly. Technically, there was a numerical advantage to the capecitabine over the endocrine therapy with palbociclib, but again, no significant difference. And so these data, in my mind, are very reassuring because it really suggests that endocrine treatment with a CDK4/6 inhibitor is performing just as well as chemotherapy. And I think really should give us comfort if we're seeing a patient, for example, in the first line setting where you're trying to make this decision in someone who may have visceral metastases, that endocrine therapy and CDK4/6 inhibition is a reasonable choice in that setting because it is associated with less toxicity, generally speaking, than chemotherapy. So with all that in mind, let's return back to our case. So again, this was a 54-year-old woman who had originally had a hormone receptor positive HER2 negative cancer and had been on an adjuvant AI when she developed disease recurrence both in the bone and liver. And biopsy did confirm it was consistent with her primary tumor, so still ER positive and HER2 negative. And she also had genomic testing suggesting a PIK3CA mutation. So now, after having seen all these data, how would you think about approaching this patient in the first line setting? Would you use endocrine therapy alone, endocrine therapy with a CDK4/6 inhibitor, or because this patient has a PI3 kinase mutation, would you think about endocrine therapy with a PI3 kinase inhibitor? Or would you even think of mTOR inhibition with everolimus with endocrine therapy, or think about chemotherapy? So maybe I'll turn to our panel of experts here and see what they think about this particular case. So Kevin, if you had this patient who came into clinic, how would you approach her?
Yeah, so thank you. So for this patient who progressed on an aromatase inhibitor, this is the kind of patient that I would think about giving fulvestrant and a CDK4/6 inhibitor. I think that, based upon the data that you presented, including the updated data from Paloma 3, as well as data that we know from Monarch 2, ultimately, we're seeing improvement in progression-free survival. And you reviewed the overall survival data. Certainly, it's nice that there's something that is targetable on the back end, including giving something like a PI3K inhibitor. But I think that with the response that you can get with these dual, giving hormonal therapy and a CDK4/6 inhibitor and the PFS and overall survival data, that's what I would lean towards next.
And I think that sounds very reasonable. I think, Erica, are there ever situations now that you have these data for CDK4/6 inhibition, are there ever situations where you do actually turn to chemotherapy in a first-line patient, and what would that patient look like?
Yeah, I'm really hard pressed to find a patient that I truly turn to chemotherapy first instead of endocrine therapy and a CDK4/6 inhibitor. We have the PEARL data that you so eloquently presented showing us that really patients do better with the endocrine therapy with CDK4/6. I think sometimes we're maybe a little bit overeager, somebody with visceral disease, to say, oh, well, it's visceral crisis. I mean, visceral crisis is really when somebody has, organ dysfunction because of that to a degree that you really feel that you need a response. So I think that's the answer. The patient that you know, has visceral crisis, needs a response now, may be appropriate for chemotherapy, but I don't think we encounter those patients very frequently in clinic. I think universally the answer tends to be endocrine therapy with a CDK4/6. And I completely agree with Kevin. I would be thinking about fulvestrant there as well. I think the trick to this case was that they teased you knowing that the patient has a PI3 mutation, but we have not seen a survival benefit, et cetera, when adding PI3 kinase inhibitors. So in my practice, CDK4/6 trumps.
Yeah, no, I very much agree. And so, you know, this may be a tricky question, Kevin, but if you had this patient and you did decide to do fulvestrant, a CDK4/6 inhibitor, which CDK4/6 inhibitor do you choose? Because we just saw the data look remarkably consistent across all these agents. And now we have updated survival data, even with Paloma 3, suggesting survival benefit. And so how do you choose? And what do you use to make decisions about picking between the three different drugs?
Yeah, I mean, I think you really could use any. And there are some features that would maybe push you towards doing one versus another. You know, for instance, if the patient has, you know, already kind of pre-existing cytopenias for whatever sort of reason, then maybe favoring something like abemaciclib makes sense. Also, you know, you'd made the comment about those concerning clinical features and the data that you had presented in terms of, you know, primary of having resistant disease. So one can also think about utilizing abemaciclib in that sort of context, but certainly you have data with the other CDK4/6 inhibitors to think about utilizing in this sort of setting. So I think, you know, it also comes down to discussing toxicities with the patients, what the patient is willing to potentially experience, including the diarrhea or gastrointestinal issues versus the neutropenia that may arise with the two other agents that are approved in this setting.
Yeah, no, it's nice to have so many choices, but sometimes it can become confusing. And so I think in that same vein, you know, if you had a premenopausal patient, let's pretend this was someone who even had de novo metastatic disease and was premenopausal. You know, Erica, how do you think about that, and what do you use in that setting? And do you think that matters which CDK4/6 inhibitor you use in an endocrine naive premenopausal patient?
Yeah, so ribociclib in the Mona Lisa trial is the trial that, you know, dedicated an entire trial to these patients, the premenopausal patients, and obviously we saw a benefit there. You know, when we break down other trials of premenopausal or you know, post, et cetera, you know, I don't think that there's probably a huge difference from drug to drug for those type of patients. So I think it's really appropriate to use any of them and what CDK4/6 inhibitor that you and your patient feel comfortable with. But again, that dedicated data is with ribociclib.
Yeah, no, I think I felt the same. It does seem that we're seeing benefit in these premenopausal subgroups with all the agents. And so, you know, I think in my mind, the key thing is make sure you suppress their ovaries and then they behave like a postmenopausal patient where we're seeing at least similar data to the overall populations. But I think, Erica, as you pointed out, one of the tricks in this case was the fact that this patient had a PIK3CA mutation. So maybe, Kevin, you could tell us a little bit about PI3 kinase inhibitors and how you think of utilizing them.
So let's spend a little bit of time talking about targeting this pathway, which is an important pathway for this subtype of breast cancer. So, you know, we can see alterations in the PI3K AKT pathway in a large number of patients with this particular subtype of breast cancer. For instance, we can see patients having PIK3CA mutations in about 40% of patients with hormone receptor positive and HER2 negative disease. And this was something that we've been hoping, a pathway we've been focusing on for some time. So, you know, this was a pivotal study which led to the first approval of a targeted agent in this particular pathway for this subtype of breast cancer. So this was Bolero-2, which showed an improvement in progression-free survival with giving Afinitor. And what you're seeing in the Kaplan-Meier curves is based upon the local assessment and then the central assessment as well. And one of the kind of prospective retrospective studies from this is that this benefit was seen regardless of PIK3CA mutation status. And similar benefits were seen with other studies with combining with Afinitor with other anti-estrogen agents such as tamoxifen or fulvestrant. So there had been previous attempts to target PI3K, and what ultimately led to an approval was with alpelisib, which is a selective inhibitor of the alpha isoform of PI3K. And the study that ultimately led to the approval was the SOLAR-1 study. And this was a randomized, double-blind, placebo-controlled trial for patients who were men or postmenopausal women who had hormone receptor positive and HER2 negative disease, who had recurrence or progression on or after a prior aromatase inhibitor. And you can see that there were various cohorts in here where there was a cohort where patients were randomized to fulvestrant plus or minus alpelisib in those who had PIK3CA mutations, as well as a cohort with the same randomization in patients who were PIK3CA wild type. And the primary endpoint of the study was progression-free survival, looking at local assessment, and secondary endpoints included overall survival. So when we look at the Kaplan-Meier curve for those patients who, in the PIK3CA mutation cohort, which was the primary endpoint, you can see that there was this improvement in progression-free survival leading to about a little less than a 6-month PFS improvement that was statistically significant. One of the things that they did in the studies that they went back and looked at circulating tumor DNA, and they saw a similar trend of improvement based upon the mutation status that was seen in ctDNA. Because of the timing of this study, only about 6% of patients had prior Cdk46 inhibition. And that's what's demonstrated in these Kaplan-Meier curves. You can look at the curve on the left, which were the patients who had prior Cdk46 inhibition, and those on the right, recognizing that that those on the left was a much smaller cohort. You can see that these are somewhat similar with a somewhat similar hazard ratio. So there was an update that was looking at the overall survival in the patients with PIK3CA mutations. And I just want to reiterate that it was really the cohort of patients who had PIK3CA mutations who seemed to benefit from getting this drug. Those who were PIK3CA wild type that did not. So if you look at the SOLAR-1 data, you can see, again, this was a secondary analysis, that numerically speaking, those patients who received alpelisib had an improvement of almost 8 months for those who received alpelisib. But again, this hazard ratio crossed 1, and the final analysis did not cross the pre-specified O'Brien-Fleming efficacy boundary. So we had been awaiting additional data, including from the BYLieve study, which was really looking at, well, how does this drug behave in patients who've previously received a CDK4/6 inhibitor? So just to talk through this study in a little bit of detail. So again, men and pre or postmenopausal women with known PIK3CA mutations, hormone receptor positive, HER2 negative, patients could not have had prior PI3K inhibition. So cohort A were for patients who previously received a CDK4/6 inhibitor and an aromatase inhibitor, and those patients received fulvestrant plus alpelisib. Cohort B were patients who received a CDK4/6 inhibitor and fulvestrant, and in those patients, the hormonal therapy backbone was letrozole along with alpelisib. And then there was a cohort C for patients who received prior AI, then had chemotherapy or endocrine therapy, and then went on to receive alpelisib and fulvestrant. And I'm going to talk about the data from cohort A and cohort B. And the primary endpoint is looking at the proportion of each of those cohorts alive without progressive disease at 6 months. So if we look at cohort A, again, these are patients who previously had received an AI plus CDK4/6 inhibitor and then went on to receive fulvestrant plus alpelisib. You can see that the primary endpoint was met in that about 50% of patients were alive without progression at 6 months. And in those who had measurable disease at baseline, the response rate was about 20% and the clinical benefit rate about 40%. And one of the known toxicities that we can see with this agent, which is really kind of an on-target toxicity that we can see when we inhibit this pathway, is hyperglycemia. So then if you look at, so this is a table that's demonstrating the SOLAR-1 cohort, and then also the BiLeave Cohort A, and then BiLeave Cohort B. Again, Cohort B is just different because those patients previously received fulvestrant, and the intervention in this cohort was letrozole plus alpelisib. You can see again that all of the patients in the BiLeave study, all of those patients received CDK4/6 inhibition. As I previously mentioned in SOLAR-1, it was very few who'd received CDK4/6 inhibition. And you can see the median progression-free survival across all of those cohorts. The response rate, you can see for BiLeave A and BiLeave B, that it's about 20% in both of those. And you can also see at the bottom of the table, AEs leading to discontinuation, and that was lowest in the letrozole plus alpelisib cohort in BiLeave B, just asking the question of whether we're increasingly comfortable with managing the toxicity that we can see from these agents. So just to bounce back to SOLAR-1, when we're looking at toxicities, again, we mentioned hyperglycemia. There are other potential toxicities such as diarrhea or nausea, some gastrointestinal issues. We can also see stomatitis and rash. So in particular, when thinking about rash, one of the beneficial ways of modifying that toxicity is to give antihistamines. So what you're seeing in the pie chart on the left are for the rates of rash when you're giving prophylaxis antihistamine. What you're seeing on the right are those rates without that prophylaxis. And there was a significant reduction in the rate of rash if you're just giving daily prophylaxis with antihistamine. So this is something that I talk about with all of my patients when initiating this agent. So just to review and kind of put all of this in context, if we think about high endocrine sensitivity, moderate endocrine sensitivity, and poor endocrine sensitivity. So let's focus first on the high endocrine sensitivity cohort. So these are patients who may be endocrine therapy naive, or who, as Sarah had previously mentioned, had progression of their disease after completion of their adjuvant endocrine therapy if they'd received it for greater than 12 months. So for those patients, we generally think about resuming an aromatase inhibitor and giving a CDK4/6 inhibitor. If they have a PIK3CA mutation, we may think about giving fulvestrant plus alpelisib. If they are PIK3CA wild type, we may think about giving fulvestrant with or without Afinitor. And then upon progression, if deemed appropriate, one may consider giving exemestane plus Afinitor, but really based upon how the patient is doing at that time. And we'd already had the conversation about, from the onset, if you have a patient who has bone-only disease, no prior treatment, a de novo patient, maybe somebody who's elderly, one would potentially have the conversation about giving single agent fulvestrant. And then when talking about moderate endocrine sensitivity, thinking about these patients who had progression between 2 to 3 years from start of their endocrine therapy, or might have had progression of their disease within 12 months of their adjuvant endocrine therapy. These are patients we may consider giving fulvestrant plus a CDK4/6 inhibitor, similar to the case that we had previously talked about. And if they have a PIK3CA mutation, one may consider giving an aromatase inhibitor plus alpelisib, but if they're wild type, giving exemestane plus everolimus. And then lastly, the patients who have poor endocrine sensitivity, patients who might have received frontline therapy, but then had progression of their disease within 2 years, or had received their disease might have recurred on adjuvant endocrine therapy. We may think about giving fulvestrant plus CDK4/6 inhibition, and we'd had the previous conversation about the times that we may or may not think about chemotherapy, but understanding and just reiterating the point that we can see pretty robust responses with these agents. And Erica had previously mentioned our definition of visceral crisis. And I can say in my clinic, it's infrequent that I really think about giving chemotherapy, just given the kind of activity we can see with dual inhibition with an anti-estrogen therapy backbone, and then giving a CDK4/6 inhibitor.
Well, thanks so much, Kevin. That was an amazing overview of PI3K mTOR inhibition. And so maybe to put that into context, we could return back to our case. So again, remember, this was the patient who recurred on the AI and had the PI3 kinase mutation. And given that she recurred on the AI, she had received fulvestrant with palbociclib and was on that for about 24 months, but then developed further progression in bone and liver. And so now this brings up, well, what do we do next after progression on fulvestrant and CDK4/6? Would you ever think about reusing fulvestrant? Would you think about fulvestrant with alpelisib? Would you think about another CDK4/6 inhibitor? Would you think about exemestane with everolimus? Or would you think about chemotherapy here? So maybe Erica, we'll start with you. What would you do in this particular patient after progression on fulvestrant and palbociclib with a PI3 kinase mutation?
Yeah, thanks, Sarah. I think the key here is this patient got benefit out of her fulvestrant and CDK4/6 for 2 years. So I'm still definitely thinking this patient is endocrine sensitive. I probably wouldn't be moving to capecitabine there. I think because of the PI3 kinase mutation, I would be thinking of something in the PI3-mTOR pathway. Because the patient has already had fulvestrant as the backbone, I would probably be thinking about exemestane everolimus for this patient with the choices given.
Yeah, no, I will say this is coming up more and more for me, where someone gets fulvestrant in the first line setting and they have a PI3 kinase mutation, and I'm thinking about whether or not I want to use alpelisib, and then I think, well, should I reuse the fulvestrant? You know, we also have data with the AI that Kevin presented from Believe, but you know, it was someone who recurred on the AI. I don't know, Kevin, what do you do in this situation? Would you use mTOR? Would you think about recycling fulvestrant again and using alpelisib, or how would you approach it?
Yeah, I agree with Erica. I think in this sort of context, the patient had endocrine sensitive disease. You know, I'd like to give some intervening hormonal therapy in combination with something before moving on to something like chemotherapy. So, you know, I do think that this also just kind of begs the question of the role of checking for ESR1 mutations and whether that will help guide that sort of decision making, because I do have some concern about utilizing an aromatase inhibitor in the context of having the known presence of an ESR1 mutation. Generally, I don't continue fulvestrant when I move on to, if a patient had a tumor that has progressed on that therapy, I generally don't continue that hormonal therapy and switch. The one caveat to that being just the context of having an ESR1 mutation and, you know, thinking about targeting that, and, you know, also the role of oral SERDs. And I know that it's a conversation that we'll get to in just a little bit, but that's certainly an emerging field as well.
Yeah, no, I think it is complicated and definitely interesting. I mean, are you guys actually checking if, like in this patient who we had NGS testing before she started on fulvestrant and palbociclib, would you ever check repeat her genomic testing, maybe get a ctDNA assay here, see if she has an ESR1 mutation? Would that influence you, Erica? Because, you know, I think if you were thinking about exemestane everolimus, would you want to know if she had that ESR1 mutation before selecting that, or how are you playing this out?
Yeah, I do profile my patients pretty frequently. I think the most common time to profile is maybe after that endocrine therapy and the CDK4/6 inhibitor, to see if there's a PI3 kinase mutation, to see if there's an ESR1 mutation. In this particular case, we knew that up front, that she had that. But, you know, the other thing is, you know, I tend to, you know, I think we can use blood for serial testing, but I also tend to biopsy my patients again every once in a while. Maybe not in this situation because she did so well for 24 months, but particularly when that progression-free survival gets a little bit shorter, because, you know, we know that cancer sometimes changes its stripes, and it's not all about the mutational status, but it's also the expression of the estrogen receptor, expression of HER2, and that can change over time as well. So I'm a big fan of rechecking markers, looking at the profile, because I think our decisions are only as good as the information we have.
Yeah, no, it's so true. It's nice that we have access to doing ctDNA testing now, because I will say I've become more tempted to send it in a patient like this. Even though I had NGS at baseline, I sort of feel less guilty that I don't have to necessarily rebiopsy, but could get that information in a pretty timely manner to help make decisions. Let's say, Kevin, you checked and she had an ESR1 mutation. Would that change your decision about what you would give her? Would you still give exemestane everolimus, or what would you do in that situation?
You know, honestly, I think if in that sort of situation, I would have some reservations about continuing exemestane and going to exemestane rather. You know, I think that based upon the SOPHIA data, where we saw for those patients who have ESR1 mutations, you know, those patients tended to respond less than the patients who received fulvestrant in that study. So that's the sort of context where, you know, if I did not have something like a clinical trial, that I would maybe think about continuing a SERD, but I think that that's where the role of oral SERDs really may come in. You know, just even in this context of, you know, there's some ESR1 mutations where things may not respond, certain tumors may not respond, like Y537S mutations, that we may see greater response with, for instance, an oral SERD. So I would, to answer your question, have some reservations about giving exemestane in that setting.
Well, that is actually the very perfect transition to talking about oral SERDs, which I do think, you know, are an exciting new area of interest. So Erica, maybe you could tell us a bit about those new agents.
Absolutely. And you two both know that I was biting my tongue trying not to say, you know, option F, clinical trial with SERD, right? So let's talk about the SERDs a little bit. We know we're familiar with this because it's in general the same class as fulvestrant. These are selective estrogen receptor degraders. So this is where instead of blocking estrogen from being around or binding the receptor, we're instead kind of binding to that receptor on the cell surface, chewing it up and spitting it out, getting rid of that signaling pathway. And so we really think that they have greater activity than aromatase inhibitors in resistant cancers with ESR1 mutations. This is well played out in the literature. Fulvestrant is the only FDA approved SERD now. What's very exciting about these new agents that are coming is that they're oral, they're pills, and so this does not require a shot, et cetera. We also think that they have greater bioavailability, and really in a lot of the phase 1 trial experience we've seen so far, they're particularly active even in patients that have already seen fulvestrant. So I think it's pretty clear that they're the superior SERD here. So what do we know about ESR1 mutations? And Kevin was really touching on quite a bit of this. The presence of an ESR1 mutation on the right side of the slide, highlighted in red, is extremely low. It's about 4 to 5% in primary tumors. However, when we have resistant metastatic you know, refractory disease, this is higher. In this graph, it's about 20%. In certain series, we've seen that number as high as even 40%. So this is definitely a resistance mechanism to blocking the estrogen axis in the effective way we do for these patients. So this is the PATA-1 trial. This was evaluating ESR1 mutations during first-line palbociclib and endocrine therapy. And I'll tell you, this trial is pretty complicated, and we've only actually seen a mere fraction of the data that we're going to get from this. But essentially, they looked at patients in this particular part of the trial that were going on to receive the palbociclib with an aromatase inhibitor anyway. And this kind of gets into this next slide. What we know is that ESR1 mutations are aggressive. Patients tend to do worse when they have an ESR1 mutation. And so the question really was, you know, is that a spot where patients are going to benefit from fulvestrant palbociclib more so than an aromatase inhibitor in palbociclib? And so what we saw here over on the right is that among the patients with ESR1 mutation at inclusion of this first line study, so again, this is going to be a small population, that those patients that had ESR1 mutations did not do as well. However, what's really interesting is if we look at who cleared their ESR1 mutation based on blood testing, et cetera, that those patients that cleared their ESR1 mutation in this yellow graph did almost exactly as well as those patients that didn't have them to begin with. And remember, on this part of the trial, everyone received aromatase inhibitor with the CDK46. Compare this to the patients that did not clear their mutation, and of course, they had a worse prognosis. So almost kind of hinting to us that the endocrine backbone may be a little bit less important when we have CDK46 here at play. So what do we know about these oral SERDs? And you'll see some tiny font here because we're lucky enough that we have a lot of these in development right now. I've included on this slide some prior treatments. You'll see really depending on when the studies were conducted, down there second to bottom with Genentech, giredestrant, fulvestrant was very infrequent, and then you scan up towards the top where the majority of patients, over 60%, had seen fulvestrant. Same with CDK4/6 inhibitors. The very early studies, we didn't see a lot of patients that had CDK, and now in some of the studies that are reporting out, essentially 3/4 of patients had already seen CDK4/6 inhibitors. For the efficacy, the second column to the all the way to the right of the slide, overall response rate is probably not our biggest measure of whether a drug is active in metastatic ER-positive breast cancer. These are not highly dividing, fast-growing tumors. They don't just melt away with treatment. Probably what's most clinically meaningful for us is clinical benefit rate, disease control rate, how long patients are able to remain on this therapy without their disease growing. And so you see ranges from 30 up to 80% depending on these. So we're going to dive into some of the specific compounds and what we know about them. This certainly is not all inclusive. There are a lot of them out there, and this is really just a selection for us. So this is the AMEERA-1 trial with imcestrant. They were postmenopausal patients. They had less than or one line of prior chemotherapy and up to 2 lines of endocrine therapy in the advanced setting. We go over here to efficacy. You can see the waterfall plot with the partial responses in green and the stable diseases in blue. And you see that most patients are getting some benefit out of this drug. We saw 34% partial responses. We saw 62% stable disease for a clinical benefit rate here of 74.3%. So pretty impressive. As far as safety, a variety, we did have palbociclib included in this study. And so we saw what we would have expected: neutropenia, we saw fatigue. We also can see some GI toxicity to the SERDs. That can be mild nausea, mild diarrhea. It does not tend to be as severe as one might see nausea with chemotherapy, or as severe a diarrhea as we may see with some of our tyrosine kinase inhibitors. Most of the time, grade 1, grade 2 at a maximum. So where are the other places that we're looking at this drug? This was AMEERA-1 that we just talked about. There's AMEERA-3, which is SERD versus treatment of physician's choice. AMEERA-4, which is SERD versus letrozole, and those are in patients with newly diagnosed hormone receptor positive breast cancer. And AMEERA-5, which is the combination of SERD with palbociclib in the first line. So really a substitute for our AI CDK4/6 here. So let's switch to another compound. This is the EMBER study. This is Lilly's compound. Again, a phase 1b trial here. You can see the waterfall plot here, again, showing benefit. I'm sure you're going to have to zoom into this slide to look at this a little bit later, but they do graph this out on the bottom of whether patients had baseline Esr1 mutations, whether they've seen chemotherapy, fulvestrant, and CDK4/6. And so you can see it's not uniform over there on the right. There are certainly patients that have seen fulvestrant getting benefit, patients that have seen CDK4/6 that are getting benefit. And so what do we see here at this 400 milligrams daily dose, which is what is the recommended phase 2 dose and moving forward? We saw in breast cancer 22% response rate and a 78% clinical benefit rate. What's unique about this study is that they also included some endometrial or uterine cancer patients because of estrogen receptor, and we saw 67% clinical benefit rate for those patients as well. And so what do we see for the safety? It's a similar story. Again, this was a single agent. It wasn't combined with CDK4/6 rather. So the side effects that we're seeing really are nausea, diarrhea, that GI toxicity that I spoke of. You'll see that there was only one patient that had anything that was grade 3. Everything else is about a quarter or 10% of patients having any of those toxicities. Unfortunately, along with most of our cancer therapies, we can see fatigue, et cetera. And so currently, they have the SERD as monotherapy or in combination with a variety of other agents we combine with endocrine therapy: everolimus, abemaciclib, alpelisib, RPI3, or trastuzumab for those patients that are both ER positive and HER2 positive. We also have a preoperative window study. So before patients go to surgery with a finite amount of the SERD, before people go to surgery to see our activity there. That can also be really helpful in looking at some of the PK and PD and making sure that we're getting the effect in the tumor that we want to. And then finally, on the bottom, there's a phase 3 study of SERD versus investigators' choice of endocrine therapy. This is EMBER-3 in patients that have already received endocrine therapy in the metastatic setting. So let's go to another one. This is elacestrant, and you guys can see us going through the slides that there are a lot of these currently out there. This is for postmenopausal women or men, again, with metastatic disease, 1 to 2 lines of prior endocrine therapy. They must have progressed on a CDK4/6 inhibitor and had up to 1 chemotherapy, and they're randomized to elacestrant versus endocrine therapy of choice. And so I love the title of this. This is SERD similars because it's a bit of word salad. We have CRANs, CIRCAs, and PROTACs, et cetera. I'll kind of walk you through this a little bit. On the top, it's actually a SERM. So you can kind of classify this in your mind as almost a tamoxifen-like compound. This is lasofoxifene. They're looking at patients that have ESR1 mutations. Next is H3B6545. This is a CIRCA, or a selective estrogen receptor covalent antagonist. Next is a CRAN. This is a Lima's compound. And then we also have Arvinas, which is a PROTAC, another twist on a degrader. So if we move to this slide, this is the CIRCA H3B6545. This was presented at ASCO. So we saw 17% partial responses. We saw an additional 43% of patients with stable disease. And then if we look at the clinical benefit rate with a conservative definition of the CRs, the PRs, and then patients that had stable disease for at least 6 months duration, that was about 40%. What I think is interesting looking at H3B6545 is that was really one of the populations that were more heavily pretreated. As over 2/3 of patients had already seen fulvestrant. Almost uniformly, everyone had seen CDK4/6, and about 1/3 of patients had had at least 4 lines in the metastatic setting. So to see this benefit, I think really just reassures us that if patients are still dependent on this estrogen access, that switching the drug, they continue to get benefit. This shows 2 populations where we think we may have a little bit increased activity, even compared to the all-comers. Patients with progesterone receptor positive tumors seem to have even a little bit increased benefit. And on the right, patients with clonal Y537S ESR1 mutations. And I kind of put both of these together. I think patients with ESR1 mutations and patients that are both ER and PR positive, we're really waiting here for patients that are endocrine sensitive based on the fact that they're PR positive, or based on the fact that they're so endocrine sensitive that this ESR1 mutation kind of grew out as a clone because they're so dependent on this pathway. So Sarah, I'm going to turn it back to you to go through a little bit of discussion here.
Oh, thanks so much, Erica. That was really a tour de force. And there's so many new agents that are in development. It is really exciting. I know, Erica, you've done a lot of work actually in this area with many of these agents. And so where do you see the future of SERDs going? And what do you think is going to happen? Do you think these agents are actually going to replace fulvestrant in the metastatic setting? Are they going to be used prior to fulvestrant, replace AIs? Or are they going to be used post-fulvestrant? Where do you see them ending up?
Is a proper response to this? Yes.
Everywhere.
No, I mean, I think the most obvious place right now is I do think they're superior to fulvestrant. I have the convenience of being pills. They work better. So I do see these replacing fulvestrant for us. I also think in the post CDK4/6 setting, fulvestrant isn't giving us the activity that we've really come to expect previously before CDK4/6. So I do think we need new agents there. Certainly they are being looked at even first line with CDK4/6. Could they even come to the adjuvant setting? Certainly. Could they be neoadjuvant in combination with CDK4/6 to downsize ER positive tumors? I think they certainly can. I think all of that will be kind of jockeyed over time, but I would expect to see these in the clinic in the next several years.
Everywhere, it sounds like. So many opportunities. So, it does seem really exciting to see the activity that you showed, Erica. I don't know, Kevin, what's been your experience with the toxicity profile of these agents? Obviously, fulvestrant is super well tolerated outside of the injection part of it. I think our patients feel well on it, just don't like that shot. But how would you say toxicities compare with some of these oral agents? And what are some of the sort of new toxicities that have emerged?
Yeah, so I think that, I think that when interpreting the data that we're seeing, I think that these are exciting class of agents. And I agree with the sentiments that are being shared. One, I think with the data that we have so far, it's important to just keep in mind that these are, patients that are kind of some small series. There's heterogeneity in terms of the amount of treatment that they might have received. Some might have received more chemo than others. And I think that that's somewhat can translate in terms of like some of the toxicities that are being reported. And there are no head-to-head comparisons. I think that, there are some differing features. Some may cause some gastrointestinal issues or some fatigue. There have been some that have been associated with having some bradycardia that we need to be mindful of. I do think that these agents really are moving forward, as Erica highlighted. But those are, and some also have been associated with some arthralgia. So I think that, further studies and larger series where we're comparing to standard endocrine therapy will really help inform, one, the toxicity, but also the efficacy.
Yeah, no, I think that's a really important point. I've struggled a little bit with all these presentations, as you say, to interpret the data because the patient populations are so different and they're pretty heavily pretreated and they're so heterogeneous. It's hard for me to sort of target it in my mind against a standard control to really get a sense of how it's performing relative to what we'd expect. And particularly because a lot of these are post-CDK, as Erica, you pointed out, in the more recent patients where our sort of control data is a little bit more limited as well. So, I think definitely very exciting and has a lot of potential. But I also think we're eagerly awaiting these randomized trials that you showed, where we're trying to see some of these head-to-head data against, for example, endocrine of choice, which we're hoping maybe some of it may be available even later this year or early next year. So hopefully more to come with more, solid randomized data to give us a signal. But maybe just to finish up on this segment, I don't know, Erica, you've again done a lot of work with a lot of these different drugs. Just from your experience to date, have you felt like one agent seems to be particularly active or have a favorable toxicity profile? Anything you can share with us in terms of your experience with them?
I don't think we have the information to be able to accurately answer that question. And it's really for two reasons. One, which I highlighted a little bit earlier, that the patient characteristics from trial to trial and when they started and who they enrolled are so different. You have trials that patients hadn't seen CDKs. You have trials where they've uniformly seen CDK. Same with the number of therapies, same with prior fulvestrant. And then the second issue is it's small number of patients, right? A couple of patients that have a particularly good prognosis or have a response can really sway this data. So I think it's going to take a little bit more experience for us to tease this out. And I think with so many agents out there that they're going to maybe even settle into some different spaces. The one thing I'll add, though, is having the benefit of having several of these agents is I've gotten a little bit of experience of switching people from one to the other in one direction or both directions. And I have definitely seen in my clinic that even after progression on a SERD, that patients will re-respond to a different. So I don't think it's necessarily, one and done. I think there's going to be some benefit for patients to see more than one.
Well, that just tells you how complicated this space is going to become if we end up having multiple options. So again, really exciting, though, to see these new drugs coming along, and very hopefully we'll get to see these randomized data soon to help us see how to use them. But maybe to move on a little bit and switch gears, we've predominantly been focusing on the metastatic setting, but what about thinking about the early disease setting and how to think about treatment there? So again, I think we'll start off with a case just to put this into context, and then we'll circle back to the case after a little bit of data. But this is a 43-year-old woman who had presented with a 4-centimeter breast mass, as well as an ipsilateral enlarged axillary node. Biopsy of the breast mass was consistent with a high-grade invasive ductal carcinoma and an FNA of the ipsilateral node. had malignant cells in it. So given the sort of locally advanced disease, she received preoperative chemotherapy with anthracycline and taxane-based treatment and went to surgery. And at the time of surgery, did have residual disease without really much treatment effect seen. So there was still about a 4-centimeter tumor. It was still high grade. And she actually had 4 positive lymph nodes that were seen. And so now seeing this, someone who really didn't have treatment response to chemo, who has ER-positive disease, who is premenopausal, what would you think about in terms of adjuvant endocrine therapy? Would it be ovarian suppression with an aromatase inhibitor, ovarian suppression with an AI and abemaciclib, ovarian suppression plus tamoxifen and abemaciclib, ovarian suppression and tamoxifen, or just tamoxifen alone? So I think lots of choices here. And again, we can circle back to this. But before we get into it, I think it would be helpful to put into context all the emerging genomic testing data that has really come about, because I think it's really changed the way we are making decisions for our patients in the early disease setting, which honestly is so helpful and has allowed us to eliminate chemotherapy for many patients. So Kevin, I know you've been involved in a lot of these studies, but maybe you could take us through some of the data.
Sure. So, we thought it would be helpful just to review some of the data that were presented at ASCO. So these are hot off the press data. So the first platform that we'll talk about is the Breast Cancer Index, which is an 11-gene expression molecular signature, which looks at 5 genes, which are molecular grade index, and then 2 genes that are really looking at HOXP13 over IL-17BR, H over I. And this particular assay has been evaluated for both prognosis from years 0 to 10, and from that kind of late recurrence setting, meaning years 5 to 10, and also for prediction, right? Looking to see, okay, once you've hit those 5 years of taking hormonal therapy, is there a benefit for extending the anti-estrogen therapy? And this particular assay has been validated in a number of prospective, retrospective studies and achieved NCCN. It was included in NCCN guidelines, both in node negative and for patients with node positive disease, particular N1 disease in 2021. So at ASCO, we saw data from B42, and for us to remember, B42 was a study that was looking at the question of the role for extending aromatase inhibition. And in this particular study, when looking at the breast cancer index and looking at the relapse-free interval, in this particular study, there was no statistically significant interaction for those patients who had H over I high or H over I low, meaning that they really didn't see in this particular study in B42 prediction benefit with breast cancer index. And then they looked at other secondary endpoints, including distant relapse, disease-free survival, and breast cancer-free interval. And you can see on the column at the right that there was no statistically significant interaction across any of these. There may be a trend for breast cancer-free interval, but ultimately, when you look at these secondary endpoints, there really was not any statistically significant discrimination for prediction. And this study is a little bit different of a finding than what we've seen with other prospective retrospective studies. And one of the questions really is the sort of events that we saw in B42, where there were very few distant recurrences that were seen in this particular study. A lot of those events were, for instance, new primaries. So then talking about a different platform, let's talk about the 70-gene assay. And of course, there are data from MINDACT, and just to review this particular study. So this was a study where if there was a discordance of clinical risk and genomic risk, those patients were randomized to chemo versus not. And at ASCO, we saw the results of the ultra low cohort. And this is a particular assay that, this particular cohort has been previously described, for instance, from Laura Esserman that were published in JAMA Oncology from a Swedish cohort, which essentially showed that those patients who were ultra low really may not benefit or really may do great and may not need any systemic therapy. So they looked at this particular cohort in the MINDACT study, and saw that ultra low was seen in about 15% of cases. And you can see where they look at the ultra low versus just low, that again, patients did seem to do well, that they really had a lower rate of distant recurrence, suggesting that this is a cohort of patients who really have an excellent prognosis. And it still kind of asks the question whether we could potentially opt out of giving any systemic therapy to these patients. But again, this was a prospective retrospective study, and I would not at this time recommend doing that. Additional data really are needed in this particular setting, including the consideration of maybe some other kind of prospective studies to help us answer this potentially in older patients. So, again, the ultra low, low, or high, when they looked at this, just to move on to B42, again, the study that we talked about for the breast cancer index, when looking in this particular study at the 70 gene assay and looking at the risk of distant recurrence, which was the primary endpoint for this analysis, again, there was no statistically significant interaction for those who are mammoprint low or those who are mammoprint high. However, one thing that is different than what was seen with the breast cancer index is that if you look at other secondary endpoints like disease-free survival and the breast cancer-free interval, there was a statistically significant difference in terms of risk for those who were mammoprint low or mammoprint high. So in this particular prospective retrospective study, while the primary endpoint of distant relapse, there was no difference, for these other endpoints, they did see a statistically significant difference, suggesting that this assay may have discrimination for benefit for extending letrozole therapy. So with that, I'm going to pass this along to Sarah, who will talk more about CDK4/6 inhibition in the operable setting.
Oh, thanks so much, Kevin. That was helpful to hear those data. And I think, while those assays are trying to help us better understand if people can get more endocrine therapy to improve outcomes, I think there are other strategies that we're also taking in addition to thinking about extended endocrine therapy, which is, can we use CDK4/6 inhibitors in the adjuvant setting to help prevent recurrence? Obviously, we saw the tremendous benefit that these agents had in the metastatic setting, making us wonder if it could work in an early disease setting. And so all three of these agents are being investigated in the early disease setting, and we've seen data from both palbociclib as well as abemaciclib for adjuvant therapy now. So some of the first data that we saw came from the PALLAS study. This is an adjuvant trial that looked at patients who had stage 2 or 3 ER-positive disease and got randomized after they completed their systemic therapy to get endocrine therapy with or without palbociclib. The trial enrolled patients, again, who had stage 2 or 3 disease, and they did limit the number of patients who had stage 2A disease to about 1,000 patients, and then predominantly enrolled stage 2B and 3 patients. You can see that about 80% of all the patients had prior chemotherapy, I think reflective of the fact that these were higher risk patients in general. However, the study did not show a benefit to giving 2 years of adjuvant palbociclib in addition to endocrine therapy, where you really see these curves are very much overlapping in terms of invasive disease-free survival as well as distant relapse-free survival. And I will say this was really surprising to most of us. I think we were all really expecting these studies to be positive given the profound benefits in the metastatic setting. And so again, I think again, we were all very surprised. So one question that came up is, well, was this study negative maybe because it did enroll some patients who had lower risk disease? And so let's look at the outcome just in the high risk patients. So those patients who, for example, had 4 or more positive lymph nodes or had 1 to 3 positive nodes and had a big tumor, a high grade tumor, which is about, almost 2/3 of the patients in this trial. But again, you're not seeing a benefit even in that high risk subgroup. So I think we couldn't purely say that this was a risk issue, that maybe it was something else. And so another issue came up was, well, did too many patients discontinue drug early? Meaning, were people really not getting treated with the palbociclib for 2 years? So was it just that they weren't getting their drug? And that's why this drug wasn't working. And in fact, there were high rates of discontinuation in this trial. As you can see, out to 24 months, a little over 40% of people did discontinue therapy over this time period. And the trial was quite strict in its sort of rules for when you had to discontinue due to neutropenia. And I think that led to many of these early discontinuations. And again, potentially could have influenced outcome, but we'll circle back to, I think probably wasn't the driver for why this study was negative. And then we saw data come out from Monarchy. So this is the adjuvant trial looking at abemaciclib in this early disease setting. The eligibility for Monarchy, though, were different than Pallas. Monarchy really focused on a very high-risk patient population. So it took those patients who had to have either 4 or more positive nodes, or if you have 1 to 3 positive nodes, you had to have a tumor over 5 centimeters, be high grade, or have a high Ki-67. And then patients were randomized to get endocrine therapy with abemaciclib for 2 years, or just to get endocrine therapy alone after they finished their systemic treatment. And so here you can see the patients that were enrolled, with about 60% of patients having 4 or more positive nodes. So again, really very high risk patients overall. And what we saw was, now we have about 19 months of median follow-up, that there was about a 30% reduction in risk of an invasive disease-free survival event. And this was statistically significant. And you can see that the curves do separate pretty early in this study. So even though, again, it's a short follow-up period, we are seeing events happen pretty quickly on endocrine therapy alone. And I think that points to the fact that this is a very high-risk patient population that is even recurring on endocrine treatment. At just 19 months of follow-up, 11% of people have recurred on just endocrine therapy alone. So again, I think really pointing to this selection of very high-risk patients, but showing benefit. Almost all patients in this trial had received chemotherapy, with about half of them having gotten pre-op therapy and about half getting adjuvant therapy. And at ASCO, we saw the data presented by timing of when they received their therapy. And what you're really seeing is that there's benefit regardless of whether people got pre-op or adjuvant treatment. And in fact, the hazard ratio is even a little bit better in the pre-op patients. But I think it just goes to show that those are probably high-risk patients and are getting benefit from the abemaciclib. Obviously, we have to put efficacy in context with toxicity. And I think the toxicity actually is pretty similar to what we've seen in the metastatic setting, with rates of grade 3-4 diarrhea being around 8%, and some neutropenia, but in low numbers. What you see with the diarrhea, though, is it really does happen very early, predominantly within the first 3 months, where people are having the grade 2 or 3 diarrhea. But once you get beyond 3 months, you're really not seeing grade 2-3 diarrhea. In fact, you're only seeing almost all grade 1. And in fact, the rate of grade 1 diarrhea gets to be pretty low over time. And so I think that's important to note, that most of the dose modifications and reductions are happening within those first couple months. And then people are on a stable dose and have, well-tolerated GI issues or no GI issues. There are a couple funny toxicities that we have to keep in mind with CDK4/6 inhibitors. Abemaciclib is associated with some risk of venous thromboembolic events. It is a low risk, about 2.4%. But it is numerically higher than what we see with endocrine therapy alone. And interestingly, the rate of VT is a little higher in the patients who got tamoxifen compared to those patients getting abemaciclib. Compared to those patients getting a aromatase inhibitor. Certainly, we know tamoxifen on its own is a agent that can cause thromboembolic events, but it is numerically a little bit more in combination with abemaciclib than you would expect with tamoxifen alone, and more common than seen in the aromatase inhibitor patients. But again, overall, the challenge is these numbers are very small. And so I think, not enough to have statistical significance between choice of endocrine treatment. And I think one thing that I thought was quite interesting is, despite the fact that we know that patients who get abemaciclib have more diarrhea than the patients who were not, when you look at overall how bothered people were by their side effects, in fact, there wasn't a significant difference when they were asked that question, which is interesting to me that I think people seem to tolerate the treatment overall fairly well. So I think it does leave us, though, with this dilemma about why we're seeing differences in efficacy across trials. So we talked about monarchy being a very high-risk patient population where abema did have benefit. We talked about PALLAS, which included both stage 2A as well as 2B and 3 patients, but did not have benefit from 2 years of palbociclib. And then there was Penelope-B, which took a different approach and took patients who had all had preoperative therapy and had high-risk features, and then gave them a year of palbociclib or not. And this study also did not have benefit with the year of palbociclib. Although one thing was pretty interesting in the Penelope-B study is this adjuvant trial that actually has the longest follow-up period. And when you look at their follow-up, you can see that if you specifically looked at the 2-year time point, in fact, there did seem to be a difference between the two arms that slowly went away. So by 4 years, there's no difference. But there was, again, this early separation of the curves where then the curves came back together again. Whereas in monarchy, again, we don't have data that far out. We see this separation that's pretty similar to the separation that we've seen in Penelope-B at this sort of similar 2-year time point, but we don't have that 4-year data at this time. And so I think this does leave us with a lot of questions about what's going to happen with longer follow-up on monarchy. Will that data hold up with more time, or will those curves potentially come back together? Does duration of the CDK4/6 inhibitor matter? Certainly Penelope-B only used 1 year, whereas both PALLAS and monarchy had 2 years of therapy. And NATALY, which is enrolling and looking at adjuvant ribociclib, actually looks at 3 years. And so would more be better? And so I think, again, there's going to be a lot more data we'll see with time from monarchy, certainly. And then as NATALY emerges, that will help us address some of these questions. But maybe we'll circle back to the case here. And so again, this was a patient who had gotten pre-op therapy and after pre-op chemo did have multi-node positive disease without really much treatment benefit from her chemo. And it is a premenopausal patient. And so maybe I'll start with Erica here. What would you do in this particular patient, and what would you recommend for her adjuvant endocrine treatment?
Yeah, so I'll say that, this is the type of patient where you kind of want to give them the kitchen sink, right? We certainly do have a benefit for premenopausal patients with ovarian suppression and AI over tamoxifen for those that are node positive. So I would definitely be in that category of the answers. I think this is a patient that I certainly would have enrolled on the monarchy trial and would be eager for her to have CDK4/6. We don't have the definitive data of that trial and it's not currently approved. So I think in the absence of that, I would be thinking ovarian suppression with an aromatase inhibitor at this point.
No, I think that's certainly a very reasonable choice. How about you, Kevin? Have you started using CDK4/6 inhibitors in the adjuvant setting? Do you feel comfortable doing it? And if so, which patients would you think about it for?
Yeah, I mean, I haven't, it's really been kind of outlier situations that I think about utilizing it. I think, what you had mentioned and what Erica was just referencing, I think that we need additional follow-up just to see whether those curves will come closer together as time progresses and patients get further away from their 2 years of the intervention. I think for this particular patient, if insurance were to cover it, I mean, this is the kind of patient that may fall into that basket of being an outlier. I mean, I think the other thing, just to kind of throw an aside, is that this is certainly the kind of patient that we would do hereditary genetic testing, right? Just based upon the Olympia data, where we would think about, potentially a PARP inhibitor if said patient had a BRCA mutation.
No, that's an excellent point. And I think, while we didn't talk about Olympia, I think certainly those data really reinforce the need for us all to be doing genetic testing on these early disease patients, because that benefit from a year of olaparib was just, I think very impressive. And we obviously want to make sure patients have access to it. Obviously, that'll be an interesting question if abemaciclib is approved and adjuvant olaparib is approved, and you had a patient such as this, and let's say she did have a BRCA mutation, how would you then think about which agent to use? And I think that'll become a more complex question. But let's pretend she did not have a BRCA mutation and make it a little easier, and say, let's pretend also abemaciclib had FDA approval. Erica, what do you think about the toxicity profile that we saw in Monarchy? Is it something you're concerned about for your patients in an adjuvant setting and with 2 years of therapy, or how have you felt about it?
Yeah, I think concern's the wrong word, right? Some of the immunotherapy toxicity I may be more concerned about, right? These toxicities, I think we've become very familiar with the neutropenia. We know that it's not complicated neutropenia. It doesn't translate to febrile neutropenia or infections, et cetera. It's really the fatigue and the diarrhea. And so can it be an issue for patients to tolerate? Certainly. In some patients, do we have to stop the drug or dose reduce the drug? Absolutely. But I know how to fix that with fatigue or diarrhea. We can stop the drug, work on some supportive care techniques and go back maybe at an even lower dose. So I wouldn't be concerned to start this in anyone now.
I sort of feel the same. I think we're used to using abemaciclib anyway from the metastatic setting and know how to manage diarrhea certainly well in our patients, and it does seem to be quite tolerable. So, I think I'm still left with a lot of questions, about all these trials and agents. And I don't know, Kevin, how have you sort of made sense of it in your head about why we've seen such different data across the studies? Do you think it was a difference in the patient populations with risk? Do you think it's a difference in the drugs and maybe their potency against CDK4? Do you think it's a difference in duration? What do you think was driving the differences in outcomes that we've seen?
Yeah, I think that, so I still am surprised about Palace, right? I think that, when we saw that press release, I was just really a bit stunned, just given what you said, that this was such an important game changer. The class of agents have been such a game changer in the metastatic setting. One thing is, this question of like cytostatic versus cytocidal drugs. I also think that, I can't help but think that maybe this has to do with the patient population. We don't have in the metastatic setting any sort of comparison between these agents, but if you look across the different studies, the hazard ratios are quite similar. I think that the designs of these studies were, just by chance enroll different populations. And I think that that's likely explaining it. I do think the duration aspect is important, which is why I think that, for instance, in Penalty B, as you mentioned, that was a year long of a duration. In Monarchy, these were 2 years. And I do think it really does beg the question, as we kind of referenced, as time progresses and they get further away from their intervention, is there really a benefit? And I think that that's what we are all, as a community waiting to see.
No, I think it's such an important point. I think Penelope B has really raised that concern in our minds. I will say I have started prescribing abemaciclib into sort of those cases that you guys were mentioning, those kind of high risk, really high risk patients, and with multiple nodes that are positive. But I actually did have a patient who recently relapsed after abemaciclib, who had been, on the study, and it's sort of made me think about what are we going to do if patients relapse after an adjuvant CDK46 inhibitor. We just talked about all the wonderful data about CDK46 inhibitors in the first line metastatic setting, but then what's going to happen if someone actually relapses on one of these drugs? What are we going to do then? I don't know, Erica, what are your thoughts there?
Yeah, that's a situation that we don't have incredibly well covered in clinical trial now, right? We have SERDs with CDKs in clinical trial, et cetera. But, we still don't really have the answer of, is there benefit for CDK beyond CDK progression? We've got the studies there, they've accrued, but we're really awaiting the results of that. I think with what we standardly have available, I would be thinking about a different endocrine backbone for that patient, a fulvestrant, et cetera. Profile that patient for sure, see if she has a driver that's making her disease so aggressive, right?
And I think that's an interesting point, is that getting those data about CDK4 beyond CDK4 will be really helpful. Again, while not technically after an adjuvant therapy, I think, again, the idea is quite similar. And, I think it'll be really interesting to see how those studies pan out, and particularly to look at the genomic classifiers, as you were also mentioning, to understand what's driving people who do get benefit versus not. But it does show you we still have a lot to learn here. But really exciting that we're seeing so many new agents that have potential to really help our patients. Well, thank you so much for all your attention, and thanks to our experts for excellent presentations. So next, we're going to turn to some questions from our audience. So one question that comes up is a good question, is how do we think about treatment choices in our patients who may be older? So how do we factor in age, for example, when we're making our decisions? Erica, maybe we could turn to you for that one.
Yeah, absolutely. It's a really good question. It's not a simple question. So, we often talk about age and the fact that, age is kind of multifactorial. There are patients at a certain age that do very well, have an excellent performance status, are physiologically quite younger, and then patients with the same age that are older. We've looked at this with some of our, medications, specifically CDK46 inhibitors. Particularly in the first and second line here with our trials. The FDA actually did a very nice pooled out analysis that was presented a couple of years ago at ASCO, when these drugs were a little bit newer. And regardless of age, patients that were even older continued and still benefited with the addition of a CDK4/6 inhibitor. So I don't think it's an issue of whether the biology is valid and whether they still have benefit. I think the issue is if you have somebody that is in particularly poor shape or has a lot of trouble with side effects because of their age, their comorbid conditions, the other medications that they may be on, where you might tailor their therapy in that way. But I certainly don't have an issue with starting CDK4/6 inhibitors in patients just because they may be elderly.
I think that's a really good point, that it's not numerical age per se, it's more sort of physiologic age, and that we need to take into account when making decisions, but very important. And another question that comes up is thinking about how we can best inhibit the PI3K/mTOR pathway. So Kevin, you talked a lot about agents like everolimus and alpelisib. Could you tell us about some of the newer agents that are in development in this space and your thoughts on them?
Yeah, so there has been interest in targeting the AKT pathway, AKT in particular, for some time. There have been some previous drugs, such as MK-2206, which was an allosteric inhibitor that caused some significant toxicities and was no longer being developed, such as rash. But then there have been other agents, such as ipatasertib and capivasertib, which are two newer AKT inhibitors that there have been some data that they can have some activity. And there was some initial enthusiasm, for instance, with these agents in triple-negative breast cancer, which has not been fully recapitulated in larger studies. But there was certainly some data in hormone receptor-positive HER2-negative disease, for instance, in the FACTION trial, where we saw that for patients who received hormonal therapy plus or minus capivasertib, that there was an improvement in outcome, including progression-free survival. And that seemed to be agnostic of having alterations in the pathway. So that's moved forward to a phase 3 trial. I think that this really could be a potential additional targeted therapy that we may have in the clinic. And toxicities that we can see from that agent include things like hyperglycemia, and then some other side effects, such as potential gastrointestinal ones. So that's definitely something that still remains very much on the radar that we're awaiting results for.
Oh, thank you so much. It's really exciting to hear about all these potential new agents that are in development that really, I think, will change how we practice and how we treat our patients. So it definitely sounds like there's more to come: SERDs, AKT inhibitors, and a lot more. So really good time at this point with drug development. So thank you all for your attention to this program, and thanks to our experts, Dr. Kevin Klinsky and Dr. Erica Hamilton, for their wonderful presentations.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com /HCT860. This activity is supported by independent educational grants from Lilly and Sanofi Genzyme. For further information concerning Lilly grant funding, visit www.lillygrantoffice.com.